has like mm, iron problem.
Right, iron problem.
Okay. Hereditary hemochromatosis. This patient has hypogonadism. This patient has hypogonadism presented with decreased libido and erectile dysfunction. The loss of morning erection suggests an organic rather than psychogenic cause of erectile dysfunction. In addition, he has features suggestive of hereditary hemochromatosis, including diabetes mellitus, joint pain, and hepatomegaly. Hereditary hemochromatosis is due to absorption of iron, excessive absorption of iron, and deposition of excess iron in the tissue. Hereditary hemochromatosis causes secondary hypogonadism due to iron deposition in the pituitary, which impairs the production of gonadotropins and other pituitary hormones, leading to decreased testicular testosterone production and testicular atrophy. Initial assessment of iron stores in patients with suspected HH should include serum iron ferritin transferrin saturation, serum iron by TIBC into 100. The diagnosis is confirmed with HFE gene testing. Concurrently, hypogonadism can be assessed with serum testosterone, FSH, LH, which are characteristically low. Treatment include therapeutic phlebotomy. Okay.
Speaking of phlebotomy, I can say that is
Negative for ketone. That means he does not have type 1 diabetes, isn't it? So in type 1, if it is not type 1, so it is not absent insulin and anti-insulin receptor antibody. And it may be E, peripheral, like resistance to effects of the insulin. Okay, differentiating type 1 from the type 2. Type 1 is insulin deficiency, type 2 is insulin resistance with relative insulin deficiency. Type 1 acute or severe polyuria, polydipsia, weight loss, ketoacidosis is common. And in type 2, usually asymptomatic, insidious, and ketoacidosis is uncommon. In type 1, other autoimmune disorders, hidradenitis, celiac disease. In type 2, dyslipidemia, hypertension, acanthosis nigricans. This patient has acanthosis nigricans. And in type 1, C-peptide is low. In type 2, C-peptide is usually elevated. In type 1, usually autoantibody usually present. In type 2, autoantibody usually absent. Okay, you want me to read the explanation? Okay, so this patient has symptomatic hyperglycemia, polydipsia, and elevated HbA1c consistent with diabetes mellitus. Although Children most commonly have type 1 DM. The incidence of type 2 DM in older adolescent is increasing with the rise of childhood obesity BMI more than 95%. These patients' age, BMI, family history of DM, and acanthosis nigricans make type 2 diabetes mellitus most likely diagnosis. Pathogenesis involves environmental and genetic factors. Excess adiposity contributes to insulin resistance. Excess adiposity contributes to insulin resistance. In adolescent, this resistance is potentiated by rising of growth hormone during puberty. Pancreatic beta cell initially produce more insulin to compensate, but become dysfunctional over time and produce less insulin, resulting in hyperglycemia. Insulin resistance alone does not always correlate with the development of diabetes, and genetic factors likely also play a role in impaired insulin secretion in susceptible individuals. Findings association with insulin resistance include central obesity, hypertension, dyslipidemia, acanthosis nigricans is common, possibly reflecting insulin effects of keratinocyte and fibroblast, manifests as velvety hyperpigmented patches in intravenous area. Patients have increased risk for candidiasis as seen in this adolescent because hyperglycemia allows for increased adhesion of candida. Hyperglycemia allows increased adhesion of the candida to the epithelium. Okay, next. Is she has thyroid problem? Yes or no? Okay, okay. I am giving answer after assuring. Okay. Okay, this patient has myalgia and proximal muscle weakness. This patient has myalgia and proximal muscle weakness with an elevated CK in a relatively young in a relatively young, otherwise healthy woman with fatigue and delayed deep tendon reflex. This presentation is most consistent with hypothyroid myopathy. Myopathy occurs in one-third of the patients with hypothyroidism and can range from an asymptomatic elevation in CK to myalgia and muscle hypertrophy, proximal myopathy, and rhabdomyolysis. Serum CK can be elevated for years before patient develops clinical symptoms of hypothyroidism. So, and there is no clinical correlation between the degree of the CK elevation and severity of the muscle disease. Inflammatory marker ESR, CRP may be normal or elevated. In the testing, initial testing should include TSH and FT4. If thyroid studies are normal, additional testing includes serological marker. If thyroid studies are normal, serological studies like anti-nuclear antibody, anti-Jo1 antibody, and muscle biopsy to be needed to rule out the myositis. Okay. Yes. Common cause of myopathy. Common cause of myopathy connective tissue disease. It may be polymyositis, dermatomyositis, inclusion body myositis, vasculitis, and overlap syndrome, like MCDD, mixed connective tissue disease. It may be endocrine disorder, hypothyroidism, thyrotoxicosis, Cushing syndrome, electrolyte, maybe due to drugs like corticosteroids, statin, zidovudine, colchicine, alcohol, cocaine, heroin, and maybe some infections like trauma, infection, trauma, and hyperthermia. Next. Okay. This patient, um, this patient has severe hyperglycemia and mental status changes. This patient has severe hyperglycemia and mental status changes. Lethargy, confusion, finding consistent with HHS. He has also prominent evidence. He has also prominent evidence of dehydration with hypotension, tachycardia, and dry mucous membrane, likely due to osmotic diuretics for severely elevated plasma osmolarity, more than 320 milliosmol per kg. Therefore, the best immediate step in the treatment is aggressive fluid treatment with isotonic normal saline, which replenishes the extracellular volume, lowers plasma mortality, lowers plasma osmolality, and increases tissue perfusion and responsiveness to insulin. HHS often occurs in the setting of type 2 diabetes mellitus. Compared with DK, HHS is associated with higher glucose level, often more than 1000 in HHS, 300 to 500 milligram per dl in DK, normal anion gap and pH, and absent ketoacidosis. Dehydration is more severe in HHS, up to 8 to 10 liter total body weight water losses due to higher plasma osmolarity and resulting osmotic diuresis. In the first hour of the treatment, normal saline should be used for resuscitation regardless of sodium level. The fluid can be changed. The fluid can be changed 0.545% sodium chloride after the second or third hour if the corrected sodium is normal. If the corrected sodium is normal, corrected serum sodium is measured by measured serum sodium plus 2 milliequivalent serum sodium every 100 milligram per dl, that glucose more than 100. Okay, it's very tough. Sorry. In the corrected serum sodium formula, in the red mark, in the green mark, sorry, in the blue mark. Okay, corrected serum sodium. I am reading it again for you. Corrected serum sodium equal to measured serum sodium plus 2 milliequivalent sodium for every 100 milligram per dl, that glucose more than 100 milligram per deciliter. Okay, I don't know how to calculate it. That's why I don't. Okay, next. Yes, it's high maybe. Is just look at the sodium. Don't look at anything. Forget all the history. Look at the sodium. You haven't seen this kind of sodium in any sort of picture? If us We have read a flowchart where it has said, like, if serum sodium is more than 145 and plasma osmolarity is more than 295, it is AVP disorder, like arginine vasopressin disorder, like diabetes insipidus. Uh, can can you remember that chart? Maybe in the previous block, as far I remember. In the previous block. Okay, I am reading the explanation. Maybe there is something in this. Okay, wait, I am calling you within 1 minute. Wait, okay. Okay, okay, I am reading the explanation. You have found the that question? Okay, no problem. Okay, in in primary polydipsia, water intake is more. Etiology is antipsychotic use, anxiety and psychiatric condition. There is low or normal serum sodium. In AVP deficiency, central diabetes insipidus, ADH is low, decreased ADH release from the pituitary gland. Idiopathic trauma, pituitary surgery, and ischemic encephalopathy. Idiopathic trauma, pituitary surgery, and ischemic encephalopathy. There is high normal or elevated serum sodium. In AVP resistance, nephrogenic diabetes insipidus, renal ADH resistance, normal or increased ADH. There may be long-term lithium use, hypercalcemia, and hereditary AVP R2 mutation. There is normal or mildly elevated serum sodium. Patients with polyuria and polydipsia should be assessed for antidiuretic hormone, also known as arginine vasopressin deficiency and resistance, formerly called central or nephrogenic diabetes respectively. Normally elevated serum osmolarity triggers ADH release, leading to increased collecting duct permeability to free water, water reabsorption, and production of highly concentrated urine osmolarity. Normally, normally elevated plasma osmolarity triggers ADH release, leading to increased collecting duct permeability to free water, water reabsorption, and production of highly concentrated urine osmolarity more than 800 milliosmol per kg. However, ADH deficiency AAVP D or resistance AVPR has decreased water reabsorption and persistently low urine osmolarity despite high despite high serum osmolarity. Two main categories, AVPD central diabetes insipidus and AVPR nephrogenic diabetes insipidus. AVPD is associated with decreased ADH secretion from the pituitary due to trauma, hypoxia, malignancy, and AVPR nephrogenic diabetes insipidus associated with normal or elevated ADH with varying degree of renal ADH resistance, can be caused by hereditary condition, ADP, ADH receptor gene mutation, significant electrolyte disturbance, severe hypercalcemia, medication, lithium, and CKD. In AVPD, serum sodium is slightly elevated and high normal, which serves to stimulate thirst and continued water intake, leading to compensate for urinary water losses. Uric acid may be slightly elevated if mild dehydration is present. More severe hypernatremia can result if the thirst mechanism is impaired. Hypothalamic lesion. Patients with AVPR typically have intact thirst mechanism that is sufficient to maintain normal or high normal serum sodium level. Next, are you there?
Yeah. Can you hear me?
Yes.
So physiotherapy
Okay, it's probably agranulocytosis, like drug-induced neutropenia. Okay, first, what are the drugs causing neutropenia? Common triggers: methimazole, PTO, trimethoprim, sulfamethoxazole, clozapine, and sulfasalazine. These are the drug and cause neutropenia. Mechanism: immune-mediated drug or metabolite binds to the neutrophil and triggers a cell-mediated or humoral response. Bone marrow toxicity: drug or metabolite directly or indirectly damages the granulocyte precursor. Manifestation usually within 3 months of drugs exposure, oropharyngeal ulceration with or without fever, and other cell lines are unaffected. Management: discontinue inciting medication, antibiotics in the setting of treatable infection, and consider granulocyte colony stimulating factor. Okay, this patient initially presented with Graves' disease, elevated thyroid hormone level, suppressed TSH, and positive assay for thyrotropin receptor antibodies. In pregnant woman, radioiodine therapy radioiodine therapy for Graves' disease is contraindicated due to risk for fetal hypothyroidism. And thyroidectomy is generally avoided due to risk for spontaneous abortion or premature delivery. Therefore, antithyroid medication is preferred during the first trimester. PTU, propylthiouracil, is recommended over methimazole due to a lower risk for congenital anomalies. However, antithyroid medications are associated with increased risk for drug-induced neutropenia, also often referred to as agranulocytosis, which commonly presents with fever, sore throat, and oral ulceration. As seen in this patient, drug-induced neutropenia occurs in up to 0.5% of patients on antithyroid medication and can increase the risk of rapidly life-threatening infection. In a patient develops symptoms of infection which, while taking an antithyroid drug, the drug should be immediately discontinued. A white blood cell count, although a white blood cell count along with blood and organ-specific culture should be obtained. A total WBC count less than 1000 warrants initiation of broad-spectrum antibiotic because antithyroid drug-related neutropenia is idiosyncratic, largely immune-mediated and not dose-related. The drug should not be continued at any dose. An alternate treatment, thyroidectomy, may be required. Okay,
Okay.
next, yes.
Then interval results from your treatment. How did this go?
Okay, it's primary adrenal insufficiency. This patient has several features of chronic primary adrenal insufficiency, including weight loss, abdominal pain, and fatigue. Hyperpigmentation is a common finding, is due to co-secretion of MSH with ACTH, which is increased in response to cortisol deficiency. In addition to loss of in addition to uh, mineralocorticoid loss of mineralocorticoid production can cause hypotension, hyponatremia, and hyperkalemia. Eosinophilia and hyperplasia of the lymphoid tissue tonsil are common but non-specific finding. Autoimmune adrenalitis is responsible for more than 90% of the cases with primary adrenal insufficiency in developed countries. It is due to autoantibody against the adrenal enzymes that are responsible for corticosteroid synthesis. Autoimmune adrenalitis can occur as in as an isolated disorder and in association with other autoimmune syndrome, primary hypothyroidism, vitiligo. Okay, okay. Why it is not other? Do you want me to read the other options? Like from F, uh, primary adrenal insufficiency due to TB is typically seen with miliary disease and is uncommon in developed countries. So, as it is unlikely that this patient contracted TB and so rapidly developed manifestation of TB induced primary adrenal insufficiency following her trip to the Thailand 6 months ago. Okay, TB may be the option. Okay, and option E. Okay, next. I think that we do not need it. It is euthyroid 6 syndrome. Like, okay, several illness often several illness often induces a catabolic state due to increased release of cortisol and inflammatory cytokine and decreased nutritional intake and associated medications. Decreased nutritional intake and associated medications. These factors can induce several changes in the thyroid physiology, which is which may be initially beneficial by reducing excessive tissue catabolism. They can they include the following: low, normal, or low TSH due to suppression of thyrotropin releasing hormone from the hypothalamus, low TSH, low total T3, and elevated reverse T3 due to reduced peripheral deiodination of T4, and low normal or low total T4 due to decreased level of thyroid hormones binding protein in the plasma. Free T4 are usually normal unless illness is prolonged. So these physiologic changes. So what are the physiologic changes happen? Like T3 is low and T4 TSH is normal. That's the thing. Okay, and the prolonged cases all are low. Okay, Okay, this patient has long-standing type 2 diabetes mellitus complicated by significant diabetic kidney disease. Initially, diabetic kidney disease characterized by hyperfiltration, increased GFR. However, as the disease progressed, GFR decreases, manifestation as rising serum creatinine level. Concurrently, glomerular protein losses lead to moderately increased albuminuria. Urine protein excretion 30 to 300 mg per 24 hour, previously termed microalbuminuria, and eventually severely increased albuminuria more than 300 mg per 24 hour. As in this patient, diabetic kidney disease can present with frank proteinuria and nephrotic syndrome. So in patients with type 2 diabetes, intensive blood pressure control is associated with reduced progression of diabetic kidney disease. Intensive blood pressure control is associated with reduced progression of diabetic kidney disease. A blood pressure target is less than 130/80 is recommended for most of the patients. ACE inhibitor ARB are preferred antihypertensive drug. These agents lower systemic and intraglomerular pressure, which may be renoprotective. So, according to educational objective, strict blood pressure control, particularly using ACE inhibitor ARB, can reduce the progression of diabetic kidney. Tight glycemic control with a target of HbA1c less than 7 also prevent the progression of diabetic kidneyosidosis. Further lowering is associated with increased risk of hypoglycemia and possibly cardiac event. Okay, what his HbA1c is 6.9, so it is normal. That's why. So if it is more than, like, if it is 9, 10, like, then this would be the answer: intensive glycemic control with insulin. Is high? No.
Does it have to be high for the patients with
After giving like antibiotic, there is this kind of feature. There is jaundice, isn't it? He has a pneumonia. Sorry, he has sepsis. Then it happens.
Wait, what is that?
I, he has sepsis. Then we have given an antibiotic that is causing these jaundice to happen, isn't it? May not. Sorry. No, not antibiotic. Maybe other thing. Like galactosemic baby has E. coli infection is much more. Yes, infection does not cause hepatomegaly. I completely ignored that point. Okay, it's galactosemia. This patient's presentation is consistent with galactosemia, an autosomal an autosomal recessive disorder caused by galactose 1 phosphate uridyl transferase deficiency results in inability to metabolize galactose to glucose, inability to metabolize galactose to glucose, leading to galactose accumulation in tissue. Symptoms of poor feeding and vomiting. Symptoms of poor feeding and vomiting develop in the first few days of life after the introduction of the galactose, which is found in the breast milk and cow's milk-based formula. Galactose accumulation also leads to jaundice and hepatomegaly, and cataract formation may occur because excessive galactose can impair leukocyte function and superoxide release. Patients are also increased risk of E. coli sepsis, which may be initial presentation of galactosemia in some neonates. Supportive lab findings include hypoglycemia, metabolic acidosis from renal tubular damage due to galactose accumulation, elevated transaminase and conjugated and or unconjugated hyperbilirubin. Although elevated direct bilirubin reflects hepatic involvement, unconjugated hyperbilirubinemia is likely due to accumulation of the galactose 1 phosphate in the red blood cell, promoting, promoting erythrocyte death. Hemolytic anemia absent RBC galactose activity confirms the diagnosis. Treatment is dietary elimination of the galactose by using soya based formula. Yes, glucose 6 phosphate dehydrogenase deficiency is characterized by inadequate NADPH production and can cause neonatal jaundice and hemolytic anemia. However, these patients' E. coli, sepsis, and elevated transaminase make the diagnosis less likely than galactosemia. Wiskott-Aldrich syndrome is an immunodeficiency disorder caused by loss of mutation in the WAS gene. Patients are predisposed to recurrent infection but have eczema, thrombocytopenia. These patients' platelet count is normal. Spherocytes, which causes jaundice and hemolytic anemia, is due to mutation in the protein spectrin ankyrin, linking the RBC membrane to its cytoskeleton. Lab evaluation would show normal transaminase and increased mean corpuscular hemoglobin concentration, finding not seen in this patient. And option E, although sickle cell disease can cause hemolytic anemia and jaundice due to unconjugated hyperbilirubinemia, and its presentation typically occurs after age 6 months when gamma chain found in fetal hemoglobin production decreases. When gamma chain found in fetal hemoglobin production decreases and beta globin chain production increases, hepatomegaly and elevated transaminase would not be expected. There is adrenal mass and clitoromegaly. Okay. Women normally produce a number of androgen, including testosterone, androstenedione, dehydroepiandrosterone, and dehydroepiandrosterone sulfate. As dehydroepiandrosterone sulfate and testosterone are produced by both the ovaries and the adrenals. In contrast, dehydroepiandrosterone is produced predominantly in the adrenal glands. The patient has This patient has adrenal mass with rapidly progressive hirsutism and virilization, suggesting very high androgen level due to androgen producing neoplasm. Most androgen producing adrenal tumor overproduce dehydroepiandrosterone. Although DHEA and DHEAS are used as diagnostic marker, they have negligible androgenic activity, and the clinical features are due to conversion of DHEA and DHEAS to more potent androgen. Therefore, this patient would most likely have elevated DHEA and testosterone level. LH would be low due to negative feedback by testosterone. Okay.
Usually a young man comes in your office with hallmark history of trauma and neuropathic symptoms. Many people classify this behavior as exaggerated
The patient has interdental spacing, enlarged tongue, so looks like everything is borrow big. It fits. Acromegaly patient has some sort of joint pain, like because their joints are getting big, and they might have, maybe it is in between either hemochromatosis or acromegaly, and patient has, like, look at the low testo and hyperglycemia. Acromegal uh, hemochromatosis cannot cause hemochromatosis uh, if
It can.
it can,
It can.
but
It can cause
enlarged tongue may not be.
inflammation and structural problem.
Yes. Okay. This patient has a characteristics features of acromegaly. including arthalgia, jaw widening, increased incidental spacing, and macroglossia. Acromegaly is caused by excessive production of growth hormone, usually by pituitary somatotrophs adenoma. Enlarging adenoma uh, enlarging adenoma can also decrease secretion of other pituitary hormones, gonadotropins, leading to erectile dysfunction and low testosterone. In addition to causing hyperglycemia, polyuria, and increasing metabolic rate, hyperhidrosis, excess growth hormone directly and indirectly via release of insulin-like growth factor 1 from the liver leads to overgrowth of tissue including bone, cartilage, and visceral organs. Joint involvement is common and involves the axial and appendicular skeletons. Growth hormone causes hyperplasia of the articular chondrocyte. Giant hyperplasia. Growth hormone causes hyperplasia of the articular chondrocyte and synovial hypertrophy, which may be visible on X-ray as joint space widening. In later stage, cartilage degeneration typically occurs, leading to clinical and radiographic findings resembling osteoarthritis. Spinal involvement may lead to kyphoscoliosis. Treatment transfemoral surgery can minimize arthropathy in the hypertrophic stage but will not reverse degenerative changes. Yes, HH hereditary hemochromatosis associated with arthropathy and most commonly presents as degenerative arthritis involving the second and third metatarsal joint. Periarticular osteophytes may be seen on X-ray, but joint spaces are narrowed. Close inspection may reveal deposition of calcium pyrophosphate dihydrate in the articular cartilage. Cranial abnormality are atypical. He has fever, hypotension, and tachycardia. There fever, hypotension, tachycardia. There is hyperglycemia, slightly elevated hyperglycemia. Okay, and he has weight loss, unintentional weight loss, and he has CT scan. It is probably thyrotoxic crisis. Yes. So these patients initially experience non-specific symptoms of hyperthyroidism, including palpitation, weight loss, impaired glycemic control. After undergoing radiographic procedure, she rapidly develops fever, tachycardia, delirium. Findings concerning for thyroid storm. Thyroid storm is usually seen in patients with undiagnosed or inadequately treated hyperthyroidism, characterized by rapidly rising thyroid hormone level. This patient with pre-existing autoimmune condition, type 1 diabetes mellitus, likely type 1 diabetes mellitus, radiologic contrast agent. CT scan of the chest with contrast is a common trigger for thyroid storm. Include physiological stressor like surgery, trauma, infection, childbirth. Clinical manifestation include cardiac arrhythmia, congestive heart failure, seizure, hypotension, coma, shock. Severe hyperglycemia may occur in patients with mm, diabetes mellitus because excess thyroid hormone increases systemic sensitivity to circulating catecholamines, leading to suppression of the insulin release and increased glucagon breakdown. Okay. Normal PTH is less than 10 to 60, 10 to 60, and phosphorus 3 to 4.5. So hypercalcemia and PTH is low. So secondary hyperparathyroidism. Uh, in primary, PTH is high, calcium is high. In secondary, hyperparathyroidism. Okay, what's his creatinine is 1.9. Glucose is, it's not primary. Is he has cancer? No cancer. Is he any sort of lung infection? He has just fatigue, poor appetite, polyuria, polydipsia, and constipation. Uh, he does not have malignancy, isn't he? Is he? He has he has only 40 pack year smoking history. Okay. No, 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 that's not normal. I have because X-ray or other feature will be present like uveitis. Okay, I got your point. It may be hypercalcemia of malignancy. Yes, uveitis, lupus, pernio, these and that, plenty of features. It's not only. I do not mean that. Okay, it's hypercalcemia. Hypercalcemia can be categorized as Hypercalcemia can be categorized as either PTH dependent, high normal or increased PTH, or independent. Humoral hypercalcemia of malignancy is the most common cause of PTH dependent hypercalcemia, and humoral hypercalcemia of the malignancy is the most common cause of PTH independent hypercalcemia. PTH independent hypercalcemia and frequently presents with very high, more than 14 symptomatic polyuria, constipation, calcium level. Hypercalcemia, humoral hypercalcemia of the malignancy should be strongly suspected in patients in the light of smoking history, systemic symptom, fatigue, poor appetite, and markedly elevated calcium or low PTH. HHM is due to secretion of PTH related protein, parathyroid hormone related protein by malignant cell, and is associated with squamous cell like lung, head or neck, renal, bladder, breast or ovarian carcinoma. Parathyroid hormone related peptide causes increased resorption of calcium in the distal renal tubule. However, parathyroid hormone related protein does not induce the conversion of 25 to 125 to the same extent as PTH does, so the 125 hydroxyvitamin D level will be low or low normal. Other causes of PTH independent hypercalcemia in malignancy include bony destruction of osteolytic metastasis, breast, non-small cell lung cancer, and non-Hodgkin lymphoma, multiple myeloma, increased production of 125 hydroxyvitamin D, lymphoma, and increased interleukin 6 level, multiple myeloma. Okay. He does not move. He was transferred paraplegia, back injury for okay. Okay, this patient with chronic residual paraplegia now has non-specific myalgia. This patient has chronic residual paraplegia, now has non-specific myalgia with bone pain and tenderness. Common cause of myalgia include inflammatory conditions, polymyalgia rheumatica, and thyroid disease. These patients' normal ESR and TSH make these less likely. In the light of his residence in a long-term care facility, this should raise suspicion of osteomalacia due to vitamin D deficiency. Vitamin D is derived from dietary source and is generated in the skin due to sunlight exposure. Dietary vitamin D deficiency can occur in patients with malabsorption or in a significant change in the dietary habits, whereas inadequate dermal production is frequently seen in patients with reduced sunlight exposure due to nocturnal occupation or residence in a long-term healthcare facility. Deficiency of vitamin D causes impaired intestinal absorption of the calcium. The compensatory rise in the PTH restores calcium level to normal or near normal, but leads to renal phosphate wasting and impaired bone mineralization. Vitamin D deficiency should be confirmed with 25 hydroxy vitamin D level, which reflects total body store. Okay, yes. Yes, tachycardia. Um, nonsense, flush skin. Maybe woman in the grave disease. It may be maternal hormone came, that's why this happens. Mat okay. It's neonatal graves usually self-resolved within months. Okay. These neonates with maternal history of Graves' disease have a low birth weight, tachycardia, and irritability. These findings are consistent with neonatal Graves' disease thyrotoxicosis due to transplacental passage of maternal TSH receptor stimulating antibodies. These antibodies bind fetal TSH receptor and cause excessive thyroid hormone release. Although neonates born although neonates born to women in active Graves' disease during pregnancy are at greatest risk, and elevated maternal antibody levels can occur despite prior treatment. Thyroidectomy and lead to neonatal disease. Presentation can occur at birth within the first few weeks of life and commonly include tachycardia with bounding pulses, irritability, and warm or moist skin as, as seen in this patient. Prematurity and low birth weight with reduced subcutaneous fat is common, and microcephaly and craniosynostosis can occur. Neonatal goiter or steering gauge may be present. These are more specific findings, often raise suspicion in infants born to mothers with unrecognized Graves' disease. Management includes short-term treatment with methimazole plus beta blocker to prevent adverse effects of neonatal hyperthyroidism on the developing nervous system, development or behavioral problems, poor growth. However, these medications can be rapidly tapered and discontinued because neonatal Graves' disease usually self-resolves over weeks to months as maternal antibodies are metabolized and cleared from the infant circulation. Yes, radi- radioactive iodine therapy and thyroidectomy are treatment options for Graves' disease due to production and secretion of thyroid autoantibodies in older children and in adults. Because neonatal Graves' disease is due to transplacental antibody transfer, the condition self-resolves and does not require ablation or gland removal. To overproduction. Yes. Testosterone is high. 46, 5 alpha. Testosterone cannot be converted into a dihydrotestosterone, that is 5 alpha. It may be. Okay. What's your thought? There is underdeveloped phallus, urethral meatus. Yes. Into yes. It's not CAH, congenital adrenal hyperplasia. Precocious puberty. There is no in classic congenital hyperplasia there is hypotension. So certainly Leydig cell can release testosterone. We are in the wrong track. Okay, initially what you thought, go with your flow. Yes, it's not 5 alpha. Maybe any high, maybe. Okay, in classic, like, I don't know why. Okay, I'm reading the explanation now. Maybe it is non-classic. Okay, these newborn with 46X6 karyotype, these newborn with 46X6 karyotype and ambiguous genitalia, 46X6 karyotype and ambiguous genitalia likely has congenital adrenal hyperplasia. The most common cause of congenital adrenal hyperplasia is 21 hydroxylase deficiency, which results in decreased cortisol and aldosterone, and increased 17 hydroxyprogesterone. The normal substrate of 21 hydroxylase 17 hydroxyprogesterone is then converted to testosterone in peripheral tissue. These excess androgen production leads to virilization like clitoromegaly, underdeveloped phallus, non-palpable gonads. In genotypically female infants, as seen in this patient, although most patients with congenital adrenal hyperplasia develop salt wasting due to deficient aldosterone, electrolyte abnormalities, hyponatremia, does not hyperkalemia do not occur until age 1 to 2 weeks. In the first few days of life, serum electrolytes are normal due to presence of maternal adrenal hormones. Patients with suspected congenital adrenal hyperplasia require prompt treatment with glucocorticoid and mineralocorticoid to avoid to avoid potentially fatal adrenal crisis. Treatment to avoid. I do not get how it has diagnosed this. Okay, I will read the other options. Okay, 5 alpha reductase deficiency causes defective conversion of testosterone to dihydrotestosterone, classically present in genotypically male newborns. Genotypically male newborns with female or under virilized external genitalia. In addition, the testosterone level is normal. Okay, in 5 alpha, testosterone level is normal. Very uncommon. And androgen insensitivity syndrome is due to defect in the androgen receptor and presence in a genotypically male presence in genotypically male 46XY newborns with under-virilized ambiguous or female external genitalia. This infant has 46XX karyotype. Placental aromatase deficiency prevents the conversion of placental androgen to estrogen. Androgen excess causes virilization in the female fetus. The mother is also typically virilized, which is not seen in these patients' mother due to transplacental transfer of androgen. And certainly Leydig cell tumor produce androgen 17 hydroxyprogesterone and testosterone and cause virilization in female patient. However, the patient is typically in early adulthood, not the newborn period. Okay, he has hirsutism, face, facial hirsutism, proximal muscle weakness. Okay, mitochondrial dysfunction. It is not the mitochondrial dysfunction. MND causes upper motor, lower motor both feature. It is not. And motor neuron disease. It has both upper motor neuron sign, lower motor neuron sign, and maybe valvar sign. Peripheral nerve demyelination. Is it GBS? It is not the GBS. He has problem in uh, difficulty in climbing or combing here, like muscle problem, dermatomyositis maybe. Is it atrophy? We are in the wrong track. It is Cushing syndrome. We have seen the hirsutism. Still, still, we do not think on that track. And muscle inflammation. What is the diagnosis of muscle inflammation? Okay, Cushing is very tough. So this patient has muscle weakness. This patient has muscle weakness associated with weight gain, bone demineralization, hypertension. This patient has muscle weakness associated with bone demineralization, hypertension, and hirsutism. Hirsutism combination of symptoms and signs of hypercortisolism. Cushing syndrome. Although Cushing syndrome most commonly results from exogenous glucocorticoid use, it can be caused by ACTH producing pituitary tumor, ectopic ACTH production like small cell lung cancer and primary adrenal disease. This patient mm, this patient requires further lab workup to determine the etiology. Regardless of etiology, myopathy in Cushing syndrome, glucocorticoid-induced myopathy primarily manifests as painful weakness of the proximal muscle, that may interfere with daily activities. It results from direct catabolic effects on cortisol on skeletal muscle that leads to muscle atrophy. Possible mechanisms: inhibition of AKT1 and anti-apoptotic signaling molecule, and interference with insulin-like growth factor signaling. Glucocorticoid also decreases myocyte differentiation and protein synthesis. Because the myopathy mostly results from breakdown and impaired regeneration of muscle rather than direct damage to the myocyte, it is classically painless, and serum creatinine kinase is typically normal in glucocorticoid-induced myopathy. ESR, ESR is also normal due to lack of inflammation. Yes, muscle weakness also caused by MND, amyotrophic lateral sclerosis, is accompanied by features of upper motor neuron disease and or lower motor neuron disease uh, dysfunction. Inflammatory myopathies sometimes present with myalgia and muscle tenderness, but painless weakness is more typical. Neither of these type of disorder would explain these patients' hypertension, hirsutism, or bone demineralization. Okay. Yes. Glucocorticoid induced myopathy. Glucocorticoid induced myopathy, it causes weakness, pain and causes weakness. There is no pain and tenderness. ESR is normal and CK is normal. It causes prominent atrophy, and lower extremities are most affected. In PMR, polymyalgia rheumatica, there is no weakness. Pain and tenderness is yes. Yes, sir, is high, and CK is normal. Stiffness of the shoulder and hips with restricted motion often coexist with GCA. Rapid improvement with glucocorticoid. In polymyositis and dermatomyositis, weakness is yes. Pain and tenderness is uncommon. ESR is normal or raised, and CK is raised. Other features like multi-system involvement, arthritis, rash, ILD, and increased risk of malignancy and statin-induced myopathy. There is variable weakness. Pain and tenderness, yes. ESR is normal, and CK is normal or slightly increased. Additive risk with fibrates and hypothyroid myopathy. Pain and hypothyroid myopathy, weakness present, pain and tenderness present, ES are normal, and CK may be raised. There is delayed diptendal reflex, myodema, hypothyroid symptoms, and abnormal thyroid test results.
Let's move on.
Is he has DK?
DK, you think so?
Maybe, I am not sure. Diet challenge that involve juice, cleansing, and he is this is on a raw vegetable.
So it's only due to reduce diet. So
It may be high potassium is due to impaired cellular uptake as it is DK. This is the first time diagnosis. Yes, this young patient with marked hyperglycemia, if glucose level is more than 300, think about DK. Uh, these young patients with marked hyperglycemia and metabolic acidosis, dehydration, and abdominal pain has DK, indicating a new diagnosis of type 1 diabetes. Calorie and carbohydrate restriction Calorie and carbohydrate restriction can cause ketosis and precipitate decay in patients with type 1 diabetes mellitus. Most patients with DK have normal or elevated uh, serum potassium values on lab testing but actually have a total body potassium deficit. The overall potassium deficit is due to urinary potassium losses from osmotic diuresis, elimination of keto acid anions as potassium salt seen in the decay, and secondary hyperaldosteronism resulting from volume contraction, which leads to potassium excretion and reabsorption of sodium in the distal renal tubule. Despite the deficit, the normal and elevated lab potassium measurements occur due to hyperosmolarity, which draws fluid and potassium passively out of the cell into the extracellular space, and insulin deficiency, which impairs cellular entry of the potassium cell by the insulin deficiency, which impairs cellular entry of the potassium by the cells and further increasing extracellular potassium concentration. And this further increasing extracellular potassium actually causing hyperkalemia, isn't it? Okay, administration of insulin during treatment drives potassium into the cell and can rapidly lead to hypokalemia. For this reason, potassium should be monitored closely and added IV fluid when whenever serum potassium is less than 5.3. Why he has given intranasal desmopressin?
for the non-invasive
Okay, LDH. Is it there is no osmolarity anything given, nothing. Electrolyte. It is SIADH. Okay, so this patient acute nausea, likely due to hyponatremia. Acute nausea likely due to hyponatremia induced by recent onset intranasal desmopressin. Recent onset intranasal desmopressin. Desmopressin is an analog of ADH used to treat CDI. It promotes the release of von Willebrand factor, and it can treat mild to moderate heavy menstrual and can treat mild to moderate heavy menstrual bleeding associated with von Willebrand disease. However, since the desmopressin induce physiologic effects of ADH, renal water reabsorption, concentration of urine, it can cause hyponatremia and excess ADH stimulation manifestation of syndrome of SIADH. Therefore, serum electrolyte should be obtained first in this patient to check for hyponatremia and to rule out the SIADH. Expected findings in this patient's SIADH include hypotonic hyponatremia due to ADH-mediated water retention, high urine osmolarity, and high urine sodium due to increased secretion of natriuretic peptide as seen in this patient. SIADH is associated with euvolemia, absence of edema or JVP or physical examination. At first, ADH-mediated water absorption slightly increases the extracellular volume, and however, increased natriuretic peptide secretion leads to sodium and water excretion, ultimately normalizing the extracellular volume. Got it?
If people who comes to the office like he recently added pills to his diet and drinking water because he has
Sweating episodes of catecholamine secreting tumor. The name of the tumor, like, uh, yes, it's not. Is it insulin in excess? Okay, physiologic state. Physiologic state, non-diabetic state. Skeletal muscle contraction. There is increased glucose uptake by muscle cell, decreased insulin release, increased counter-regulatory hormone, endogenous glucose production, limit glucose uptake. Endogenous glucose production limits glucose uptake and glucose level maintained. But insulin treated state, skeletal muscle contraction, increased glucose uptake by the muscle cell, but insulin level not physiologically regulated, impaired endogenous glucose production, persistently high muscle glucose uptake, and risk of hypoglycemia. This patient likely experiencing recurrent hypoglycemia, presenting with both neurogenic sweating, tremor, palpitation due to autonomous activation, and neuroglycopenic confusion, impaired consciousness due to inadequate CNS and glucose supply symptoms. Hypoglycemia generally occurs when circulating insulin levels are excessive for the associated glucose level. As blood glucose level fall during activity or fasting, insulin secretion normally Insulin secretion normally decreases at the same time the production of counter-regulatory hormone glucagon increases to stimulate glycogenolysis and gluconeogenesis in the liver. However, patients taking exogenous insulin are vulnerable to exercise-induced hypoglycemia because insulin continues to be released from the injection site, and despite falling glucose level in addition, strenuous exertion may cause change in the skin perfusion that can lead to increased insulin absorption. Patients with CKD are increased risk of hypoglycemia due to detailed clearance of insulin by the kidneys. These patients often have additional factors such as altered nutrition and autoimmune dysfunction that can delay the normal physiologic compensation. No, stomach from thyroid origin. Uh, okay, so this patient has painless thyroiditis, silent thyroiditis characterized by acute thyroid, acute thyrotoxicosis with ma- acute thyrotoxicosis with mild thyroid gland enlargement and suppressed TSH. Painless thyroiditis is an autoimmune disorder thought to be a variant of Hashimoto thyroiditis, although the latter classically presents with chronic hypothyroidism. A similar disorder can be seen within a year following pregnancy, but would be properly termed as postpartum thyroiditis. The follicular inflammatory reaction in painless thyroiditis may be occasionally low, lead to persistent hypothyroid phase, but most patients recover normal thyroid function. Patients with hyperthyroidism with a suppressed TSH should undergo thyroid radioactive scintigraphy to distinguish painless from Graves. With painless thyroiditis, radioiodine uptake is decreased, suggestive release of preformed thyroid hormone. In contrast, Graves causing hyperthyroidism due to increased synthesis of the thyroid hormone. So radioiodine uptake will be diffusely increased, and extrathyroidal manifestation exophthalmos myxedema are often present. Okay.